In this discussion, we'll focusing on discussing hematology concept and different types of anemia. So remember that anemia is a deficiency in the number of red blood cells, or also known as erythrocytes, or the quantity of hemoglobin, or the volume of the packed red blood cells. And the volume, what we're talking about, is the hematocrit. And remember, for this concept, you really have to know the normal levels of the following. And the thing with anemia, it's not a disease, but it is a pathologic process. And it's a prevailing condition with many diverse causes such as blood loss, impaired production of erythrocytes, or increased destructions of erythrocytes. And remember that red blood cells are very important in transporting oxygen, and any problems in any of that can lead into hypoxia. And you've learned hypoxia in respiratory concept, that with hypoxia, your patient will have signs and symptoms of shortness of breath, difficulty of breathing, decreased O2-sat, ABG changes, patient will become more acidotic. So you really have to understand this concept because it's related to other concepts too that you already know. So before we go over on the different types of anemias, let's just review this. And remember that you've learned this concept when we discuss fluid and electrolyte imbalances. So what does this mean? It means that any changes, okay, in the ions, the positive and the negative ions, like the potassium, the sodium, the chloride, any alteration there's a possibility that we have a problem in the plasma content. So we're looking at the fluid volume, we're looking at any malnutrition, right? We're looking at, the acid base of the patient and see if it also are the contributing factors for a patient to have an acid base imbalances, right? So this is just, reminding you that, again, this concept also has a relationship with fluid and electrolyte and acid base imbalances. Now, let's just review, before we get to different types of anemias, how red blood cell is produced. Because when you understand the very foundation of this concept, you'll be able to understand why are we giving blood to this patient, why this patient needs bone marrow transplant, why this patient needs vitamin B12 supplements, folic acid supplements, ferrous sulfate. It's just knowing how red blood cell is produced. If you understand this, anemia is a concept that will be easier for you to manage. Okay, so let's just discuss red blood cell production. You've learned from anatomy and physiology that red blood cell is produced in the bone marrow, right? And the thing with RBC production, it's not only the bone marrow has the participation. There's so many factors that can affect it. For example, the kidneys. Remember that the kidneys produce erythropoietin, which is also very important in RBC production. Another thing, there are different substrates that can affect RBC production, like iron, vitamin B12, folic acid, and heme. So these substrates, these are the substrates or substances that have an important role in RBC production. So any alteration of any of these substrates, let's say a deficiency in iron or vitamin B12, folic acid, or heme, can affect directly the RBC production. That's why your patient can have anemia. Now, if your patient has any kidney disorders, let's say chronic kidney disease, renal insufficiency, any that is related to kidneys, can again lead into later on anemia. Okay? And when you look at the RBC, how it looks like, as you can see, it should be round and should be smooth, it should be concave. Any alteration in the shape or the form of it can lead into anemia, like sickle cell anemia, right? What else? So again, you see, it's related to each other. The different concepts that you already know from pathophysiology. Another thing is that RBC survives up to 120 days. That's it. Nothing more, nothing less. 120 days. And after 120 days, the old RBCs will be removed by the phagocytic cells from the spleen and the liver. Okay? So what does it tell you? Any abnormality in any of this, like let's say your patient has splenomegaly due to right-sided heart failure, or your patient suffered splenic sequestration because of sickle cell crisis, can later on lead into anemia, right? Or what if your patient is alcoholic, or patient suffered from, let's say, opioid toxicity, and of course the liver works so hard to metabolize those drugs to be out in the system, can later on lead into anemia. And liver cirrhosis that you've learned in pathophysiology can later on lead into anemia. So as you can see, any problems in the substrates, kidneys, liver, spleen, bone marrow, and even GI tract can later on lead into anemia. And we will discuss why GI tract. Okay, and I hope this overview will help you to be able to understand the different types of anemias. Okay, so now let's start discussing the first one, which is the iron deficiency anemia. And I mentioned earlier that iron is one of the substrates that can affect the RBC production. So any deficiency on it can affect the RBC production. That can later on lead into anemia. And the thing with IDA, or iron deficiency anemia, it's the most common nutritional disorder in the world. So when you look at World Health Organization website, when you look at CDC website, or even when you look at the nutrition website, there's so many evidence-based practices there about IDA and how can we help our patients. Because the thing with IDA, the most common susceptible population are those who are very young. So let's put here risk factors, the very young population. Those who have poor diet, and those who are women that are in their reproductive years. Because remember, women have menstruation. They have menstrual cycle every month. So again, that blood loss right there can lead into iron deficiency anemia. Now, let's go back. Where does iron is produced? Okay, I hope you can still remember where it's produced. But as a review, not produced but absorbs. Remember that iron, we can get iron from our diet. Okay, and iron is absorbed in the duodenum. So if you remember, let's say this is the stomach right here. Okay, this is the pyloric sphincter. This is the cardiac sphincter, or the esophageal sphincter, lower esophageal sphincter. And this is the pylorus. And then this area right here is the duodenum. So iron is absorbed there. So in short, any GI alteration type of surgery can affect iron levels. Okay, or any manipulation in the GI tract can affect iron levels. Remember that. And we will discuss about the different GI disorders later on. So what are the signs and symptoms of IDA? So as you can see here with the signs and symptoms, when you look at it, you already know that if there is alteration in RBC production, for sure there is alteration in oxygen delivery in the system. and it can affect level of consciousness. It can affect the cardiac output. That's why the blood pressure is really low. Patient can have shortness of breath. What else? Patient can have splenomegaly as a compensatory mechanism. Patient's stool color will change because, again, iron is absorbed in the duodenum. Now, what are the diagnostic tests for us to suggest to check the, iron and why this is happening? So, of course, for the diagnostic test, we have to check serum iron level. Serum, so we need to do a blood draw. Okay, we need to check the iron level. We also have to check total iron binding capacity. You can check the normal levels in chapter 29. What else? You can also suggest that maybe your patient needs endoscopy or colonoscopy. Okay, and these two procedure, endoscopy, the upper GI endoscopy. Remember, the approach here is from mouth, down to the stomach, and just to check if there's any bleeding there. While colonoscopy, the approach is from the rectum up to the lower GI. Now, with these two types of procedure, remember your patient will be NPO, at least 8 to 12 hours before the procedure. Remember your patient, especially with colonoscopy, your patient needs enema prior the procedure. Your patient will be sedated on both of them. Remember, you need consent because both of these are invasive. And after the procedure, let's say with endoscopy, you have to check for gag and swallowing reflex, and you have to check the respiratory status of the patient. Well, with colonoscopy, you just need to monitor any possible changes in their stool, and also you have to check bowel sounds just to make sure, and any fluid and electrolyte imbalances. Just in case, you just want to make sure you're covering all your baseline. And if you want to know more nursing responsibilities, kindly go back on your chapter 29. So remember, with IDA, your main goal is to treat the underlying cause. Because what if the underlying cause is malnutrition or alcoholism? Then for malnutrition, we have to teach them about the foods that are high in iron. And we have here dark green leafy vegetables. We have here broccoli. We have here poultry. We have quinoa, greens. These are all high in iron. So we have to educate them that these are good sources of iron. Now, not only that, they can also have an oral or, IV supplement of iron. Okay, remember, in pharm, you've learned the adverse effects of this and also the nursing considerations when you're giving iron supplements. The ferrous sulfate, you would know if it's iron. You would know because of just looking at the name of the drug. Okay, ferrous, that's iron. Okay. Another thing is that if alcoholism is the cause, then we have to educate the patient about their alcohol intake. Now, other nursing management would be, we have to look at the other factors, like if they are premenopausal and pregnant women. And with that, you'll learn that more in OB. And the thing with OB, the nutrition part is very important as part of health teaching for pregnant women. Those who have lower socioeconomic backgrounds, of course, a lot of patients, if they have low educational level, you have to teach them about foods that are high in iron. What else? Remember that if they're taking any iron supplements, we have to reassess them. Okay, and that's very important that
we have to reevaluate if the nursing management that we did to this patient and the medical management are effective by reassessing their response to the therapy. So we have to check the hemoglobin level, we have to check the RBC level, we have to check their iron level. Okay, and the thing with this is that it doesn't change drastically like few hours after. No, it really takes 2 to 3 months for us to say that this patient is getting stabilized. Now, remember, we have to monitor patients who require lifelong iron supplementation for potential liver problems related to the iron storage. So, even we're giving them iron supplements or other source of iron, we have to check the patient's liver function tests. Okay, because if any abnormality here, it means we have a problem with iron storage. So what are the liver function tests? AST, ALT, and bilirubin total. Okay, and that's it for IDA. So now let's move on to megaloblastic anemia. In megaloblastic anemia, there are two types. We have folic acid deficiency anemia, and we have vitamin B12 deficiency anemia. So let's start with folic acid. And I mentioned this folic acid earlier, that folic acid is very important in RBC production. Now, the thing with folic acid deficiency is that it's due to impaired or defective DNA synthesis. Okay. And the most common causes of folic acid deficiency is the diet. So it's like IDA, right? So it's the diet. What else? Diet, any malabsorption syndrome, any drugs that interfere the absorption of the folic acid. So with the drugs, we have here methotrexate, and you've learned in pharm that methotrexate is an immunosuppressant drug and it can alter folic acid absorption. Not only that, anti-seizure meds can also alter folic acid absorption, like phenobarbital, phenytoin, chronic alcohol use. Okay, so again, alcoholism, anorexia, and dialysis. So any patients who are in dialysis treatment can affect folic acid absorption. So why is that? Because folic acid or folate aids in the production of RBCs, and you've learned that earlier. Okay, and it works with vitamin B12 and vitamin C to help the body digest and utilize proteins. As you can see, this folic acid is very, very important. Any deficiency of it can affect vitamin B12 levels and also vitamin C levels, and it will affect the digestion, okay, and the protein levels. Okay, so as you can see here on the right side, right here are the folic acid foods, okay, that you can suggest to your patient to take, like cauliflower, asparagus, broccoli, leafy green, okra, mushroom, avocado, beetroot, papaya, oranges, seeds, nuts, beans, pear, and lentils. Okay, these are just some. And when you take your nutrition class, you will learn more about, the sources of folic acid that we can suggest for the patient to take. Now, what are the clinical manifestation of folic acid deficiency anemia? You will see some changes again with their, level of consciousness. So your patient might seem depressed, have trouble in concentrating, being forgetful. Okay, when you look at their mouth, they will have mouth sores, swollen tongue. They will lose their appetite, right? And if your patient is a pregnant woman, then there's a possibility that there will be birth defects, poor growth,
okay, fatigue, and gray hair. Okay,
So these are just some of the clinical manifestation, and of course, you will see a lot of GI disturbances because we discussed why GI. Okay. Now, when you look at the levels of folic acid, the normal folate level or folic acid is 3 to 16 nanograms per ml. Okay. And remember, any changes in the folic acid level, you also have to check the levels of vitamin B12. Okay. Now, for the nursing management, is that for this patient, of course, they will have folic acid. Let's put here treatment. Folic acid supplements. And of course, you have to educate them about their diet. Okay, for folic acid deficiency anemia. Okay. So, let's move on to here. There is folic acid here. Supplements. Okay. Now let's move on to vitamin B12. Okay. The thing with vitamin B12 deficiency anemia, again, it's kind of related to folic acid deficiency anemia. Okay. And the thing with vitamin B12 is that it needs an intrinsic factor for it to be absorbed in the gastric area. Okay. Now, when you look here in this image on your left side, you see if there's a lack of intrinsic factor, your patient cannot absorb vitamin B12. Okay, and the most common cause of cobalamin deficiency is pernicious anemia. Okay, it's the most common cause. Let's put here. I remember before someone asked me, is vitamin deficiency anemia is also known as pernicious anemia? No, it is the most common cause of cobalamin deficiency, the pernicious anemia. Okay, remember that pernicious anemia is the most common cause. Wherein the gastric mucosa doesn't secrete intrinsic factor. Okay. And again, looking at it, any patients who have GI surgeries or any alteration in their GI function can later on lead into vitamin B12 deficiency anemia. Not only that, if a patient is taking excessive alcohol, okay, excessive alcohol, or even hot tea, what else? Those who are smoking, okay, those who are taking H2 receptor blockers, and you remember in pharm that H2 receptor blockers are the cimetidine, ranitidine. Okay, and we will discuss that more in GI concept. Those who are using PPI, proton pump inhibitors like pantoprazole. Okay, you guys know that because when you go to clinical, you've been giving Protonix, also known as Protonix, but it's pantoprazole to prevent peptic ulcer disease. And also those patients who are strict vegetarians, okay, they are at risk to have vitamin B12 deficiency anemia. All right. So, what are the signs and symptoms of vitamin B12 deficiency anemia? So, you can see here, patient can be at risk for infertility, hypothyroidism, depression, cognitive decline, low energy, and numbness. And patient will have neuromuscular manifestations. And patient will have weakness, ataxia, impaired thought processes, and even confusion. Now, with the diagnostic studies for this patient who have vitamin B12 deficiency anemia, you really have to check the vitamin B12 levels. Okay, because we have to know how severe this disease process is. We have to check that. We have to check the, of course, folate levels again, and we discuss it in the folic acid deficiency level. We also have to check the anti-intrinsic factor antibodies. We also have to check upper GI endoscopy. And we talked about the nursing considerations for upper GI endoscopy earlier. And the biopsy of the gastric mucosa. Okay, just to rule out if there's, let's say, patient has, stomach cancer, then probably that's the cause why your patient's having vitamin B12 deficiency anemia. Now, what is our treatment for this patient? Now, the thing with dietary management, because we've been talking about that in IDA, folic acid deficiency anemia, it's not used for cobalamin replacement. Regardless of how much cobalamin is ingested, the patient is not able to absorb it when intrinsic factor is lacking, or if absorption in the ileum is impaired. So therefore, lifelong administration of cobalamin or vitamin B12 is needed. Okay, remember that. Because sometimes we think, it's vitamin B12 deficiency anemia. Let's just give foods that are high in vitamin B12. But nope, it's not gonna happen. Your patient needs a lifelong administration of cobalamin. It can be oral, or it can be parenteral or IM injection. Okay, so for IM, just a review, you need to review how to do an IM injection, and you know that you have to do a Z-track method. You can go back to your fundamentals of nursing book here, and these are the different sites for IM injection. We have deltoid, we have vastus lateralis, we have ventrogluteal. Okay, as you can see, dorsogluteal, it's not recommended. Okay, but again, other nursing management here is that you have to ensure that the patient is protected from burns and trauma because of a diminished sensation to heat and pain as a result of neurologic impairment. Because with vitamin B12 deficiency, they will have neurological impairment. Another thing would be you need to follow up any neurologic difficulties that were not fully recovered, because it can really affect the neurofunction. And if the patient has a potential for gastric cancer, then we have to reassess that patient. Appropriate screening for gastric cancer. We have to look back on it. Okay. All right. So I hope that so far that the different types of anemias we discussed are pretty much clear about IDA, vitamin B12 deficiency, folic acid deficiency anemia. Okay. Now let's discuss thalassemia. And thalassemia is also another type of anemia, and it's a group of diseases involving inadequate production of normal hemoglobin or decreased erythrocyte production. Okay, so let's just put here decreased erythrocyte production. Now, it is due to absent or reduced globulin protein. So this is an autosomal recessive genetic disorder. Now, in regards to this, is that with thalassemia, there are two types. And for sure, you guys are familiar with this, ladies, that there is thalassemia minor and there is thalassemia major. Okay, thalassemia minor, usually your patient will be asymptomatic, so no symptoms. While with thalassemia major, it's life-threatening. Okay, why it's life-threatening? Because it involves, physical and mental retardation. Not only that, it's also related to your patient will be jaundice, so liver is affected. Your patient can also have splenomegaly, cardiomyopathy, okay, and thrombocytosis. So just looking at it, it's not good. Okay, liver, spleen, cardiac, and patient will have thrombocytosis. That's not really good. So we really have to monitor this patient properly. Now the thing with thalassemia is our management will focus on giving them blood transfusion. Okay, so let's put here the management will be blood transfusion. And again, in NCLEX, you really have to know how to administer blood. Another thing would be, what are the adverse effects or the blood transfusion reactions that you have to watch for, and what do you have to do. And remember, we discussed this in NR226. If you're my students or if you're with Dr. Lucy's students, we went over with those blood transfusion reaction. And if you still, if you forget about it, in chapter 30, there's a table for the blood transfusion reactions, and you can go back also to your fundamentals of nursing. Okay? Now, with blood transfusion, for this type of patient, we give it with deferoxamine. So if you're familiar with this, if you go back to your farm book, deferoxamine, I'm gonna write it clearly here. Deferoxamine is a chelating agent. What do I mean by that? Chelating agent means that it prevents iron overload. Okay, I'll put an X here. It prevents iron overload. Iron overload is also known as hemochromatosis. So we give BT with it, okay? And it's given via sub-Q. Okay, remember, subcutaneous injection. We also administer folic acid to them. But again, check their folic acid level. We also give them zinc. We also give them ascorbic acid. And ascorbic acid, the good thing about this one is that it increases urine excretion of iron. It increases urine excretion of iron. So as you can see, we're trying to prevent another, problem here, or another complication, which is hemochromatosis. And of course, if their spleen is too big and the healthcare provider recommended splenectomy, that also a part of the medical management. And HSCT, or hematopoietic stem cell transplant. I think I have an image here. Okay, HSCT, let's put here hematopoietic stem cell transplant. With this one, it's a transplant, so you want to prevent transplant rejection there. So you'll be giving a lot of immunosuppressants and corticosteroids to your patient. Okay? Again, immunosuppressants plus corticosteroids, not a good combination. Your patient will be at risk for infection, risk for hyperglycemia that you have to watch for your patient very closely. And of course, if your patient is risk for infection, your patient needs to avoid crowds. Okay? And you have to monitor their WBC level, blood glucose level. Okay? And your patient needs to be a neutropenic precaution. If you're not familiar with neutropenic precaution, it's like reverse isolation. So any any visitors that comes in, or even you in the patient's room, you have to gown up. Okay, if you're not familiar with it, review it again, because this precaution will not go away. Pretty much most of the disease process that we will discuss in adult health 1, adult health 2 will be like that, and in other classes. All right, so the next type of anemia that we need to talk about is polycythemia. And the thing with polycythemia, what's going on is that there is a high concentration of red blood cells in the blood. So just knowing that there is an increased concentration of red blood cell in the blood, you know that it can lead into hyperviscosity of the blood and hyperbulimia. So here, let's put here, it can lead into hyperviscosity and hyperbulimia. And the thing with polycythemia vera, and you've learned this from patho, is that there is primary and there is secondary. So with primary polycythemia vera, it's a chronic myeloproliferative disorder leading to increased WBCs, RBCs, and platelets. Okay, and this is very common in male patients, who are in their 60s. Okay, well, secondary type of polycythemia is, it could be hypoxia driven or hypoxia independent. What do I mean by that? Now, when you say hypoxia driven, it's related to the physiological response. Okay, while hypoxia independent is usually related to a tumor. Hypoxia independent is due to a tumor. The tumor might be a benign or a malignant one. Okay? Alright, so if your patient has polycythemia, knowing that there's a possibility that they can form clots, the most common signs and symptoms would be intermittent claudication. Not only that, it can also cause thrombophlebitis. So you really have to check the pulses, the color, and the sensation of the extremities of your patient. Also, because of the hyperviscosity of the blood, your patient will have hypertension. Okay, so you have to monitor their blood pressure. And also, you've learned hypertension, if it's out of control, this can later on lead to heart failure. So you have to monitor this, and you've learned this from cardiac concept. Now, since it can cause heart failure, most of it would be more on the right-sided heart failure. So you will see also splenomegaly to this patient, hepatomegaly. Okay, hepatomegaly. Okay, and since the RBC level is really high, okay, there's a possibility that there will be destruction of RBC and production. So you have to check the uric acid level, because there's a tendency that the uric acid level will be elevated, and this is due to high RBC production and destruction. Okay, so your patient will have hyperuricemia. So for the diagnostic tests, what do we check for this patient? Of course, we check their CBC, focusing on their WBC level, RBC, and platelet count. Okay, Not only that, since there's a tendency the uric acid level will be high, you have to check the uric acid level. Okay? You also have to check their cobalamin level. And you have to check their bone marrow. So you can suggest bone marrow examination. Could be bone marrow aspiration biopsy, just to rule out other causes, or just to rule out if there is hypercellularity of the RBCs, WBCs, and platelets. Now, what would be the treatment? Now, the treatment would be focusing on removing those excessive amount of RBC, and that can be removed through phlebotomy. Okay, phlebotomy is a way of removing the excess amount of RBC, and with this, we have to monitor their hematocrit level, or the volume of the red blood cells. Remember, for this type of disease process, you have to avoid iron supplements. Remember that. Avoid iron supplements. And since there is hyperviscosity of the blood, we recommend them to hydrate more. Okay? Another thing, we have to give them myelosuppressive therapy, because again, if the bone marrow is producing too much RBC, we need to suppress that. And the most common drug that we give is hydroxyurea. And the thing with hydroxyurea, you will learn that more when we discuss sickle cell anemia, because we also give that same drug. And this has an effect on the bone marrow, or the myelosuppression. We also give them low dose of aspirin, because again, if there's high RBC, there might be a formation of clots. So we give also aspirin. Now, if the patient is or are women of childbearing age, we give them anagrelide. And anagrelide reduces platelet count. Okay, it decreases platelet count. And for sure, you've learned this drug already in pharm, anagrelide. And since the uric acid might be high, we also give them allopurinol. And that decreases the uric acid levels in the body. Okay? So that's it for polycythemia. Now, let's discuss the last topic, and that is aplastic anemia. And aplastic anemia is a type of anemia wherein the patient has a decreased number of RBCs, WBCs, and platelets. Okay, decrease RBCs, WBCs, and platelets. Okay, and the thing with aplastic anemia, it's often acquired. It could be idiopathic, wherein you really don't know what the cause is. And based on research, the thing with aplastic anemia, it's autoimmune. Okay? Or it can be caused by chemical agents and toxins. What do I mean by that? Probably, like benzene, insecticides, alcohol. Or it could be drugs, like anti-seizure medications, the antibiotics that you're giving, NSAIDs, thyroid medications, allopurinol. Okay, let me write it here. So, might be autoimmune. I'll say might be, okay? I'm not saying that this disease process is really an autoimmune disease. No, it can be caused by, there are other causative factors like chemical agents, could be drugs. I'll put the drugs here, like NSAIDs, antimicrobials, the antibiotics that you've learned in pharm, anti-seizure meds. And we just talk about allopurinol can also increase the risk for a client to have an aplastic anemia or thyroid medications. Not only that, radiation. So if your patient undergone radiation or had viral or bacterial infections can also predispose them to have aplastic anemia. And the thing with the aplastic anemia, by just looking at the etiology of it here, if there's decreased RBC, you know that their oxygen delivery will drop, right? So you're thinking of alteration in neuro, with cardiac, patient will have chest pain, palpitations. With respiratory, patient will have shortness of breath. What else? For the WBC, again, this that predisposes them to have, infection. Their risk for infection. So when you look at their temperature, there's a possibility that they have low-grade fever. And if there's a decrease in platelets, then your patient has thrombocytopenia. So your patient will be at risk for bleeding. So by just looking at the etiology itself, you already know what to check for this client, right? For the diagnostics, you have to check CBC of this patient, focusing on RBC, WBC, and platelets. You also have to check their iron levels, their total iron binding capacity, the serum iron level. You have to check that. And we can also suggest bone marrow aspiration biopsy. In your chapter 29, you will see your nursing responsibility for this diagnostic test, and you really need to know it. Okay? What do you do before? What do you do during the procedure of bone marrow aspiration? What do you do after? And of course, the most important for bone marrow aspiration biopsy is before the procedure, you need to make sure your patient void. Okay? During, you need to make sure that the patient, stays still in their position, their own left side lying position, or right side lying, or fetal position. Okay? So kindly look at your nursing responsibility for bone marrow aspiration biopsy. So what do we do to this patient who have aplastic anemia? Again, we're focusing on the levels. If there's decreased RBC, then we give blood, right? Or probably your patient needs, I'll put here treatment, probably your patient needs HSCT, and we discussed this earlier. What else? If their WBC is really low, then their risk for infection. So just be mindful of giving immunosuppressants, and you already know with HSCT, they will be in immunosuppressants and corticosteroids. So just imagine if their WBC is already low, and then you're giving those meds, then again, it can exacerbate the condition of the patient. If your patient's platelets are low, then there's a possibility you'll be giving blood transfusion. So again, watch them for any bleeding and check their levels. Okay? And that's pretty much it for aplastic anemia, and I hope that this video discussion will help you to understand it more and how do we manage them. Thank you.